Trauma Nursing Core Course. Autotransfusion. Autotransfusion or autologous blood transfusion involves collecting and reinfusing a patient's own blood instead of using banked donor blood. It's indicated when a patient has active bleeding of more than 100 ml per hour or is collecting more than 300 ml in a blood collection device. For example, trauma patients and patients undergoing cardiothoracic procedures may undergo autotransfusion. Various types of autotransfusion systems exist. For example, a water-sealed chest tube drainage system or a modified chest drainage ATS may be used. Some chest tube drainage systems allow for collection of blood by more than one technique. Contraindications to autotransfusion include coagulopathy, renal or hepatic insufficiency, septicemia, presence of malignant cells in the bloodshed, and blood being collected in the system for longer than the facility permits for autotransfusion. Contraindications may be overruled if the patient is exsanguinating and there's an inadequate supply of available banked blood. Equipment: gloves, gown, mask and protective eyewear or mask with face shield, vital sign monitoring equipment, ATS, compatible electronic infusion device, blood administration set, microaggregate microemboli filter and set for use with an infusion device, 500 ml of normal saline, optional, prescribed anticoagulant, labels, 14 to 24 gauge venous access catheter. Preparation of equipment. Assemble the ATS according to the manufacturer's instructions. Inspect all equipment and supplies. If a product is expired is defective or has compromised integrity, remove it from patient use. Label it as expired or defective and report the expiration or defect as directed by your facility. Label all collection bags with appropriate patient identifiers. Implementation. Verify the practitioner's order. If the situation isn't an emergency, confirm that informed consent has been obtained and that the signed consent form is in the patient's medical record. Gather and prepare the necessary equipment. Perform hand hygiene. Confirm the patient's identity using at least 2 patient identifiers. When possible, explain the procedure to the patient and family if appropriate, according to their individual communication and learning needs to increase their understanding, allay their fears, and enhance cooperation. Assure the family that staff members are nearby to provide care. Obtain the patient's vital signs for baseline comparison. Follow the practitioner's orders for the amount of drainage required to initiate the ATS. Raise the patient's bed to waist level to prevent caregiver back strain. Collecting the patient's blood, perform hand hygiene, put on gloves and other necessary personal protective equipment to comply with standard precautions. If ordered, add an anticoagulant to the ATS collection bag before collecting blood from the patient. Connect the ATS collection bag to the patient's drainage bag or chest tube. Trace the tubing from the patient to the point of origin to make sure that you're connecting the tubing to the correct port. Where blood is collecting the attached ATS collection bag, prepare a new collection bag. Clamp the tubes in the new collection bag to eliminate the risk of air entering the system. Clamp the patient's drainage tubing as indicated. If the collection bag is part of a water seal system, clamp the tubing connected to the water seal drainage unit. Disconnect the filled ATS collection bag from the patient system, maintaining sterility. Place the collection bag on the compatible electronic infusion device. Attach a new collection bag to the water seal chamber or to the patient's chest tube to allow for collection of more blood. Make sure that all connections are secure and that the clamps on the collection bag and patient drainage tubing are open to create suction for drainage. Transfusing the patient's blood. Verify that the patient has a patent acceptable venous access device available for blood administration. The access site may be peripheral or central using 14 gauge to 24 gauge venous access catheter. Insert an IV catheter if necessary. Prepare the blood administration set. Prime it with normal saline solution. The infusion can be administered through a compatible electronic infusion device if available. If you're using an infusion device, make sure that alarm limits are set appropriately and that alarms are turned on, functioning properly and audible to staff. Connect the filled ATS collection bag to the blood administration set with a 40 microgram microaggregate microemboli filter. Filters are used to reduce microembolization. Trace the tubing from the patient to the point of origin to make sure that you're connecting it to the proper port. Route the tubing in a standardized direction. If the patient has other tubing and catheters that have different purposes, label the tubing at the distal, near the patient connection, and proximal, near the source container, ends to reduce the risk of misconnection if multiple IV lines will be used. Clinical alert. Make sure that all air has been purged from the entire blood administration set before infusion to reduce the risk of air emboli. Start the infusion at the prescribed rate. Assess the patient's vital signs 5 to 15 minutes after the start of the transfusion and at an interval determined by the patient's condition in your facility. Check for drainage, tube patency every 2 hours or at an interval determined by your facility. Monitor the drainage amount and type hourly or in shift increments as necessary. Assess the patient for signs and symptoms of a blood transfusion reaction, such as chills, tachycardia, hypotension, hematuria, and temperature greater than 101 degrees Fahrenheit or 38.3 Celsius. However, blood transfusion reactions are unlikely with autotransfusions because patients receive their own blood. Clinical alert. Don't autotransfuse blood that remains in the ADS for longer than 6 hours after collection, and make sure that the transfusion is completed within 4 hours of starting the infusion. Repeat the procedure if prescribed. Completing the procedure. Return the bed to the lowest position to maintain patient safety. Discard used supplies in appropriate receptacles. Remove and discard your gloves and other personal protective equipment. Perform hand hygiene. Document the procedure. Special considerations. Clotting factors, plasma, and platelets may need to be replaced if large volumes of blood are reinfused. Certain religious groups refuse blood transfusions because they believe that blood is sacred. However, some of these groups permit autologous blood transfusion if the blood is kept in a continuous closed circuit. The Joint Commission has issued a sentinel event alert related to managing risk during transition to the new International Organization for Standardization Tubing Standards, designed to prevent dangerous tubing misconnections, which can lead to serious patient injury and death. During the transition, trace all tubing and catheters from the patient to their points of origin before connecting or reconnecting any device or infusion at any care transition, such as to a new setting or service, and as part of the handoff process. Additional protective measures include routing tubes and catheters having different purposes in different standardized directions, labeling the tubings at the distal and proximal ends when there are different access sites or several bags hanging, using tubing and equipment only as intended, and storing medications for different delivery routes in separate locations. The Joint Commission has issued a sentinel event alarm concerning medical device alarm safety because alarm-related events have been associated with permanent loss of function or death. Among the major contributing factors were improper alarm settings, alarm turned off inappropriately, and alarm signals not audible to staff. Make sure that alarms limits are set appropriately and that alarms are turned on, functioning properly, and audible to staff. Follow facility guidelines preventing alarm fatigue. Complications. Complications associated with autotransfusion includes fever, hypotension, myocardial infarction, infection, particulate and air embolism, and thrombocytopenia. Blood transfusion reactions are unlikely with autotransfusion. Documentation. Document the procedure including the rationale for the autotransfusion, amount and type of anticoagulant if used, amount of blood loss, amount of blood infused, date and time that the collection started and ended. Document the patient's vital signs before, during, and after the procedure, and any other assessment data obtained. After the procedure is complete, document the patient's tolerance, any complications, any interventions performed during and after the procedure, and the patient's response to those interventions. Document teaching provided to the patient and family if applicable, their understanding of that teaching, and any need for follow-up teaching.